Hey, Dr. Jonathan Shepard here, host of Ask the Doctors. It's my privilege to be with you once again, take a little break, and now we're back up and going. Ask the Doctors. It is my privilege to be with you once again on this live broadcast as we discuss various medical issues that affect not only our physical bodies, but our mental well-beings. I am the Chief Medical Director at Hope Health Systems, which is the sponsor of this particular broadcast. And if you're in need of any mental health services, we'll be glad to service you and be able to um, bring some help and closure if you're in need of direct care services. I'm letting it scroll at the bottom. HopeHealthSystems.com, located in Woodlawn, Maryland, suburb of Baltimore. It is so good to see you all today. I am grinning from ear to ear because I've missed being on the broadcast. And so I am just glad that we have this time together again. Have such an important topic today. I'm going to get right into what we're going to discuss. We're going to bring on two experts who are going to help me discuss the issue of Parkinson's disease. Parkinson's disease is actually the second most common involuntary movement disorder. And we'll talk a little bit about that. So you might say, well, what does that mean, Dr. Shepard? Involuntary movement disorder. And our experts will break it down. I don't want to steal their thunder, but they will help us to understand what Parkinson's disease is. I want you to go ahead, share and like as we are opening up this discussion. As you see me go, put my head down, that's because I'm probably answering questions as people are coming on live. Go ahead and get your neighbors, let them know, hit them up virtually or through text or messaging, or maybe we need to call them and say, you need to hear this show about Parkinson's disease because it's actually impacting more of us than what you would truly believe. So for tonight, today, wherever you might be, I have some guests with me. And my first guest is one who's not a stranger to this broadcast, as he's been on with me several times, and he's a mentor of mine, and that is the Dr. Terrence Roan. I'm going to bring him on at this time. Dr. Roan, how are you, sir?
Hi, sir. How are you?
Oh, I'm doing well. I'm doing well. Good to see you out there in LA, sunny LA, I'm assuming.
Mm-hmm.
I just saw where I think it was last year, or was it this year, that you just had the driest period. I think
It's this year.
recorded.
Yeah,
Yeah.
it's really dangerous out here right now. They're getting ready to put a ban on watering your lawn. It's bad because we've had to drop so long. We've just really hadn't been able to catch up.
Wow. Well, again, we're definitely keeping those out there in prayer because you need water and we need it to grow, especially in a time of inflation. My God, we don't need our prices to go up on anything else. So we need the rain. Thank you, Dr. Roan. Tell the people a little bit about yourself and what you do.
I'm a pulmonary critical care physician. I've been practicing for 25 years. Graduated from USC, doing my residency and my fellowship there. I am now the national director of pulmonary services for the CareMore Health Plan, which is a subsidiary of Anthem. We take care of primarily seniors. I'm also a bishop in the Church of God in Christ, a pastor of the Mount Sinai Church of God in Christ. I'm also the bishop of Brazil, where we take care of pastors and 85 churches and growing. So I'm doing two full-time jobs at the same time. So if I look a little sleepy, that's why. But God is good. I enjoy what I do. I'm excited about the work of the Lord, and I do thoroughly enjoy my medical practice.
That's great. Oh man, awesome. Thank you. And I have one of my friends and colleagues who were just discussing. It's been 20 some years that I have known this gentleman, have watched him as he has grown into a wonderful colleague and physician. I am speaking of Dr. Antonio Graham. How you doing, Dr. Graham?
I'm doing well. Thank you for having me on the show.
Absolutely. And I am so glad that you joined us. He was with me not too long ago, where we did a show on Black men, if I'm not mistaken, and their health. And so thank you for being here once again. And let's just go ahead, tell the people about yourself so we can jump on in. People want to hear about what you do. They're anxious to hear about this topic. So let's go ahead.
Sure. So I am Dr. Graham. I'm a geriatrician by training. I am a geriatrician at the Atlanta VA here in my clinical appointment. And then my academic appointment is an assistant professor at Emory University School of Medicine. Prior to coming here to Atlanta, I was at Johns Hopkins University School of Medicine for geriatric fellowship. I do a lot of medical education, a lot of DEI work at the level of the medical school and residency and fellowship training here at Emory.
Oh, wow. Awesome. Yeah, he was here in the DMV area where I was practicing, and we let him slip through the cracks and go back to ATL. I'll let y'all put you on notice, ATL. We are sending Dr. Graham back here. we need we need him in this area. And and actually I was able to refer some people to him, not just jokingly.
Yeah.
I was actually able to refer some people to him, and he was able to help them out. So yes. Thank you for your work. Thank you for your service. Just want to go ahead and acknowledge the people who are out there. Dr. Hayes, thank you, sir. I appreciate your message that you sent to me earlier. Beverly Carter is out there. Harold Harrison, Elaine Winfield, thank you so much. Go ahead right now. If you are listening, go ahead, put a comment in the chat. In the comment section, let me know you're listening. Let me know that you're watching. Let me know that you're engaging. We're going to do our best to stay engaged with you. We want you to send us your questions. Where can you find 3 Black doctors at one time who are experts in their field? On Ask the Doctors broadcast. That's where you can find it. And so we want to take advantage of this time. Thank you so much for sharing. So let's jump right on in. We're talking about Parkinson's disease. All right, Parkinson's disease. And I want to make sure people understand Hope Health Systems, myself, we are providing information, not treatment today. I always want to make sure that I lay that foundation. And we're going to be lifting up people who may have been diagnosed with Parkinson's, not trying to talk about anyone, say anything negative. We just want to lift this area up because it's been in quote unquote the news, and people have been asking more and more questions about it. So why don't we start with you, Dr. Graham, since I introduced Dr. Rowan first? Why don't we start with you, Dr. Graham, and just explain to us, and then Dr. Rowan pick up where he leaves off. What is Parkinson's disease?
So in a global sense of what Parkinson's disease is, it basically is the part of the brain that is responsible for movement and gait and other issues, or other control rather. What happens is those cells that are responsible for, or the neurons that are responsible for those particular movements that I described, begin to kind of die. There's a big word called apoptosis that we say in the medical and science world. So apoptosis of these cells, or death of these cells, occur. And what happens is, as enough of this particular area of the brain begins to die, you begin to see symptoms. In our world, we call them motor symptoms. We call them, you might see rigidity, meaning the person is more rigid. A tremor may occur, typically in the upper extremity, like in the arms is upper extremity, just to give you an example. And you kind of have to have these 3 criteria, or 2 of the 3, to make a diagnosis of Parkinson's. And so if you have those, then from there, a treatment plan can kind of be established in terms of what to do about it. So what drugs can you do? And without going into that too much, because I think we wanted to talk about just the disease itself, some people may get nervous because they get a tremor, right? But not every tremor is Parkinson's, right? Because there has to be these other constellations of symptoms. And so we want people to know that, just because someone has a tremor, don't immediately think, oh my God, or you have a tremor, and you immediately think it's Parkinson. That's not necessarily true. Because again, these other associated symptoms have to be there in order to make a diagnosis. So that's one thing I kind of want to talk about it and hopefully dispel that myth. But there's very kind of specific things that we look for when we think someone or suspect that someone has Parkinson's. As a geriatrician, in my line of work, so to speak, I see people over 65. So I see Parkinson's quite a bit because there's data to support that roughly 1% of Americans over 65 have Parkinson's disease. So just as a result of that, in the work I do, I see quite a bit of Parkinson's even in my own practice. So with that being said, at least having a knowledge of if these types of symptoms occur, going and seeking a professional opinion to say like, well, I have this tremor and I'm having difficulty speaking, or my voice is getting softer, or I'm having issues with writing. Like if all of these things kind of begin to occur together, that could be, so to speak, an alarm, right? For you to raise to your primary care or raise to neurology. If you have access already to a neurologist, probably start at primary care, and then primary care decides kind of which way to go and refer you is typically the way it starts. But that's kind of it's a really 360 high level view, but I think that's a good place to start. And I'll let Dr. Rohn continue to give more detail to that.
Well, Dr. Graham is a geriatrician. My field is pulmonary critical care, but I do a substantial amount of hospitalist work. So I see most of my patients are 65 and above too. I only add that Parkinson's has to do with the death of those cells, that apoptosis that he was talking about, which leads to the loss of the cells that produce dopamine. And when you don't have those dopaminergic cells producing dopamine, it actually leads to some of those manifestations that you see, because there is a denervation of certain areas of the brain called the substantia nigra. And without going to all that, the bottom line is that depletion of dopamine leads to a cascade of events that actually manifests itself in those things, the rigidity and the tremor that he was talking about. Also, there's a constellation of findings that you see as late manifestations as people have the disease for a long period of time, and they continue to see that denervation of that part of the brain. But that's all I would add to that.
Wow. So we're diving into Parkinson's disease, all right? And so what I'm hearing from you all say, there are three, what we could say, cardinal features of it. And I want to talk a little bit more about this as we break it down. Those three features would be: number one, tremor; number two, rigidity; and number three, bradykinesia. All right. And so, Dr. Rohn, why don't you take one of those three and let's break it down a little bit more so people understand, because people need to really hear what is Parkinson's disease.
Dr. Graham, thank you for saying what you said, because a lot of people think if they have a little shake, they got Parkinson's. A lot of people shake because they get older, just because by virtue of age, you might be start to shaking. One of the most common differential diagnoses that we run into, even more common than Parkinson's for shaking, is benign familial tremor. You just shake. It's just in your family, in your genes, and you shake. And the shake or the tremor of Parkinson's has a distinctive look to it. It's a resting tremor. So a resting tremor is different. And it also, there's something called pill rolling. So I'm doing it fast, but you see people doing like this, you'll see pill rolling. Sometimes you will also see with that tremor what we call fasciculations. That's a late manifestation, but you see these little tremors within the muscles themselves between the hands. You'll see those types of things happening as manifestations of late Parkinson's disease as well. So that tremor of Parkinson's is very distinctive. And so if somebody's just shaking like this with an intentional tremor, that's probably not Parkinson's. But resting tremor, that's Parkinson's, especially when you combine it with all those other things. Now, tremor is the thing that I'm most familiar with. I'll just touch on bradykinesia. There's a slowness of movement. Everybody just starts moving slow, and the actions are very intentional because they're trying to get from one place to another. And it looks like they're almost doing it on purpose, but there's a method to their madness, just trying to force themselves to do things. And I think where I've seen this most, Dr. Graham, is in persons that are close to me and close to Jonathan, in the voice, where it gets a real challenge to speak, because you got to take a deep breath and make your respiratory muscles force the air through your vocal cords to get the sound out. So that's what we've been seeing.
Wow. Oh, wow. That's awesome. That the way which you just broke that down. I think we're going to need to stay there a little bit. Dr. Graham, I felt that you want to say something more on that. Go ahead.
Yeah, so I just want to add, I mean, Dr. Rome did a great job of giving the overview of those two. And then the third thing is rigidity. And so rigidity is kind of a big word for just stiffness. So it can occur on one or both sides of the body. What you often see is the arm swing of people. So like all of us have kind of a normal arm swing that we do, period, whether we realize we do it or not. What happens is with someone with Parkinson's, you see a reduction in that arm swing. They don't have that as much. And it may be on both sides or it may be on one, is another thing. So as Dr. Ron was saying, if you see this kind of constellation, big word meaning all these symptoms together, then you do have to think, if, okay, this person has an asymmetric resting tremor, and they're saying, yeah, I am slowing, so to speak, down some, and I have bradycardia, like, you know, and typically it doesn't happen like that. But if you, as a primary care doctor or anybody else, hears these symptoms, that's going to raise, right, for them, like, we need to have you evaluated for Parkinson's. And so I think just being aware of that, and that they kind of have to all be together. I think Dr. Roman, of course, did a great job of just saying, like, yeah, every tremor, you can't get nervous and say, okay, oh my God, I have Parkinson. And I think to push the point he made about the difference between what we call a resting tremor, which means you're just sitting down. Let's say you're holding your hand like this, and you're shaking. And an intentional tremor is you're reaching for something. So let's say you're reaching for your pencil or your phone, and when you begin to reach, you start. That's kind of the difference between those two types of tremors. And that's helpful, especially in looping together these symptoms for a diagnosis of Parkinson's. So I just wanted to also just add a little bit more to that.
Sure.
No, that's good. That's good. Because we need to know the difference between a resting tremor and an intentional tremor.
Right.
And thank you, Dr. Rowan, for talking about benign tremors, because we see that, and that does come with normal aging. And so and that's why we have you here, Dr. Graham, to know the difference between normal aging versus what is a true movement disorder.
Yes.
Involuntary movement disorder, such as Parkinson's disease. So thank you. Aeneas Francisco from Brazil is joining us. Bishop, you see him out there. Sarita Watson. All right. I love it. Hattie Cobb, Mother Hattie Cobb here in Baltimore, and some others joined us. So thank you. The question has been raised: is this hereditary? Let's answer that question first. Is Parkinson's disease hereditary?
Dr. Graham, I'm going to refer to you on that one because I'm really not sure.
So my understanding from the literature is that there is a component, there is a genetic component, but it's not like, so to speak, a definitive, okay, if your family member has Parkinson's, you're absolutely going to get it. It does make you more prone to having it, but not, because there are lots of Parkinson patients who have no family history of Parkinson's, but they still have it.
Sure.
Sorry, Dr. Shepherd.
No, go ahead.
But if you do have a family member, first degree relative, that has it, there is a slight increase in your risk or chance of having it, is my understanding.
Gotcha.
But not like a 1-to-1 correlation, right? It's not like BRCA breast cancer where, okay, you know what I mean? Like the likelihood is extremely high because that correlation, but not necessarily like that for Parkinson's. However, there is a familial component.
Gotcha. Because what we're seeing, as I've read up on Parkinson's disease, in particular for this broadcast, but I've already was doing it because of all the news that's been coming out with those persons who have been affected, who many of us know. I've seen that there's an increase in it. There's a rise in the number of people who are getting Parkinson's disease. And I'm not sure if we truly understand why that is, because it really leads into the next question. That's part A of the question. Do we know why there's been a rise in the number of people who are getting Parkinson's disease? And does it affect or impact people under the age of 65?
Yeah, it does.
Yeah.
You do have cases of people, younger people, for unbeknown reasons, no rhyme or reason. Just be Michael J. Fox is a very classic example. Very young, a vibrant young man who developed Parkinson's quite early and is in the latter stage of his disease process. So, although as a rule it affects people at later ages, there's some people that just gets to later in life, or earlier in life.
Mm-hmm. Gotcha. Do you know, Dr. Graham, if there's a reason why we're seeing an increase in numbers, or just people are living longer?
Yeah, I was going to say that's the most recent thing I've seen, is that because people are living longer and the life expectancy in the United States is increasing, we are seeing a higher prevalence. Because as I said to you earlier, or to our guests as well, that approximately 1% of all people over the age of 65 in America have Parkinson's. So if we have more people in theory reaching the age of 65, which we do in the country, then the prevalence of Parkinson's likely is going to follow that, right?
Okay.
So that is one. I'm not saying that's the answer, but that's definitely one answer for why there's an increase.
Yeah, that makes sense. Makes sense. So tell me this. If I recognize some of these symptoms in myself or someone who I know, what do I do? Because that can be a very sensitive topic. I've known some people who were offended because they people assumed that they had Parkinson's disease and they didn't have it. I've even seen where some people who actually had Parkinson's disease, people were kind of mean towards them, so to speak, and didn't really understand what was happening with them. And then it comes out that they have Parkinson's disease, and they're like, "Oh, maybe I should have dealt with that person a little bit softer or more sensitivity." So help me. How do we get people to go to find out if they really have it? And part B, how do we educate others on how to be able to treat those persons who have Parkinson's disease? I know it's a long-winded question, but
well,
y'all got it.
I think that the rule would be to approach them out of love and concern. Those whom we care about will approach them and say, "Hey, doc, something's wrong with you. I'm noticing you're shaking. I'm noticing you're leaning. I'm noticing you're weak. I notice you're shuffling your feet. I think you need to go get that checked out." When you approach a friend or relative, someone that you care about, in a spirit of love and humility, and say, "Hey, I really think you need to get this looked at." That's more of the approach that you want to use. Is you're not condescending, you're not being mean, you're not being hateful, you're not being spiteful. You're approaching that concern, and they'll hear you. They'll hear the tone of your voice. They know you. You have relationship with them. It's best to we're most effective in persuading those with whom we have relationship with. And so when you've established relationship, you've established trust. So when someone you trust says, "Hey, I think you need to get this looked at," you're more inclined to take their advice into consideration than somebody that's coming at you all, sideways and saying, "Hey, man, you don't look right," that type of thing. They're not going to hear you. And also the incentive for you, the caring individual, is that the sooner this person gets looked at, the sooner they can get under treatment, whether that be medical or otherwise, to preserve the function that they have and to hopefully reduce the acceleration of the pace by which they move to a debilitated condition. The earlier the medical community gets involved, the more likely the patient is to have a better outcome. Although we can't stop it, we can't cure it. Well, we certainly can introduce drugs and other things to help them optimize their function while they're dealing with this.
It's good. It's good. Dr. Graham, do you want to add anything to that?
Yeah, I would say being persistent too.
True.
There's a lot of literature that says Parkinson's is diagnosed a lot later because the medical community, i.e. physicians and others, tend to sometimes explain away people's initial symptoms. And so they don't necessarily put the puzzle together to know, like, clinically, that this is likely needs to be evaluated. And so what we find is that there's a lot of data supporting that the diagnoses are found later and later. And to Dr. Rohn's point, if they were found earlier, you could preserve quality of life for much longer. And honestly, as he said, with Parkinson's, our goal is to preserve quality of life for as long as possible. And the drugs we have are not magical per se, but they do delay progression for significant amounts of time. And so again, if this is like your life, right, or someone you love, you would want them to be as functional for as long as possible. So getting these things identified sooner than later are extremely important. And so I hope that with some of the things that we're discussing, that if people do even, and I guess I want to say this too to the listeners, it's okay to say, hey, I'm not sure, but I want to be checked out, because that's still better than I let this go until all of a sudden some of the late onset symptoms start happening. And then it's kind of like, well, now we know for sure, as Dr. Rohn was saying, like the changing of the voice and more pronounced shuffling of the feet, like all these other things that might have been, so to speak, prevented or slowed down. I'll say slowed down had we gotten an earlier diagnosis. So I think there's just that agency to not be afraid of the healthcare system and not to ask good questions if you are experiencing these kinds of symptoms.
That's true.
Wow, that's good. That's good. Elaine Winfield was mentioning or asked the question: is this the condition that Muhammad Ali had? And I believe that is yes.
True.
Is that correct? Correct.
That's correct.
All right.
Mm-hmm.
And so that really leads me into this. And Bishop Rohn, I want you to speak to this, because I think that you're the best person to speak to the sensitivity of this. We already named some famous persons: the boxer Muhammad Ali, the actor Michael J. Fox, the presiding Bishop Emeritus of the Church of God in Christ, recently disclosed that he is one who has suffered from Parkinson's disease. I'm careful how I say that, because people are not their condition.
Yes.
That's why I hesitated. I'm so careful now. Just because you have a condition doesn't mean that you are that condition.
That's right.
I'll pull back out of that, because I feel that I won't digress too much. But too many times people think that they are their conditions, and you are not. But Dr. Rohn, speak to that. How do we handle this news that was disclosed regarding Bishop Blake?
Well, first of all, I want to be very careful in my comments as well, because I'm one of his physicians. So I've been with him through this journey for several years. And Dr. Bishop Blake has a great medical team that works with him. And what we're talking about on this broadcast today is everything that Bishop has publicly disclosed. We're not disclosing anything that Bishop hasn't already made public. I want to make that very clear. Bishop stood in front of his congregation on closed circuit television, streaming all over the world. He said, I've been functioning with this for 10 years. And people gave it applause. That's good. And I think that's a good point to make on this broadcast. Bishop Blake was signaled early that he had this issue, and he went to get treatment very early. And he had a team working with him to help him, from physical therapy to speech therapy to medical therapy, all kinds of people on board to make sure that every system that was being affected by this disease was properly managed. And that's the only way he's been able to function this long. It was only now that he decided, you know what, I've crossed that threshold where I don't think I can do the job that I need to do on my own. So I'm going to bring on my son as co-pastor. That's what happened. And again, that's what he disclosed. But I think Bishop Blake's case is an excellent case of early intervention and trusting the medical community and having a support team around you to get the help that you need as soon as you can, so you can be optimized in your function. Did I answer the question? What was it? You asked the question.
Well, yes.
Okay.
Yeah. No. Yeah. Thank you. No, you answered it wonderfully, because we have to know how to be able to approach the situation with sensitivity. I think one of the things that we fail to do in the Black community, and even within the Black church, but Black community as a whole, is that when we see one of our great leaders who have been stricken with the disorder, with the disease,
Mm-hmm.
we fail to recognize the strength of how they have endured that particular disorder. I just said something, y'all. Seriously, it just
Well, let
go ahead.
me speak to that. And you brought me back on track. So,
Mhm.
to your point, hats off to Bishop Blake, because
Mhm.
he didn't let his pride get in the way of what needed to be done.
Wow.
From admitting he had the diagnosis, from being under the authority of his physicians, from being under the confidence of his family and his trusted friends, to making his own decision that I need to pass the baton. Let's roll the tape back. There's a reason he didn't run for another term for presiding bishop, because he knew, hey, I know that if I give it up now, I'm going to do better than if I hang on and try to deal with this. Nobody knew that he had this, but he decided it's time for me to emeritize myself and step aside and let the next man come in, rather than fight another election and try to stay in there for 4 more years, because he and his family came to the decision it was not in the best interest of his health, nor was it of his church, which is his most valued priority, of course.
Mhm.
So it was very important to him to make those decisions. I applaud him again. Praise God for our emeritus presiding bishop, because he doesn't have the mentality, you die in this thing. And that's, we got too much of that going on in Kojic right now, man. This is being taped, huh? I'll say it if you can hear me. There's too much of that going on in Kojic, man. You die in this thing. I mean, can I tell you a story? I want to tell you this story.
Okay.
Okay. So,
You
okay.
good?
When
You good?
I was the state youth leader of Southern California, first jurisdiction, the biggest jurisdiction brotherhood. Yay. Okay. So I went to the National Youth Convention for the first time to meet my colleagues, the supervisors of the youth department, the women and the men. I saw men on canes. I saw women on walkers. I saw people in wheelchairs, 85 and 90. I'm not kidding. 85 and 87 years old. She was the chair lady of the jurisdiction for the youth, because these folk would not give it up. It was I was incensed. I couldn't believe it that these folk, because this is the mentality of our church and many people, is you die in this thing. There is very little of a very small sense of a succession plan, of handing over the baton to bring on the next generation, to have pride in being a good leader. Good leaders produce other leaders to take it on, so you can enjoy seeing that person move on in the next stage. I know this is not what your broadcast is about, but thank God again for our presiding bishop, because he understood for the good of the church. It's let me hand the baton off. For the good of the church, let the next man have it. And that's something we need in our church, is a succession plan for men to say, for the good of the ministry and for the kingdom of God, let's pass it on when our time comes. So this disease process that we're talking about tonight is a teaching moment, probably the last teaching moment that Bishop Blake will ever have, to show us how to do it, to show us that there's no shame in admitting I have a physical problem. There's no shame in admitting I've come to the place where I am no longer at the capacity physically to carry on. It's an excellent teaching moment, and we hope that others will learn from it, and that our church will be a better church, because other men will see what our presiding bishop emeritus has done and follow his example, whether it be bishops of jurisdiction, whether it be superintendents in districts, whether it be pastors in local churches, to say, okay, enough is enough. I'm the Moses. Let me find my Joshua before I die on, and don't let the church die with me. That's all I got to say.
Thank you, Bishop. And you brought it right on back. I love it. This is good. One of the things I want to do is dispel some of the myths about Parkinson's disease, and we've done some of those things already. Stay with us, you all. This is getting good. This is getting really, really good, and you're hanging tight with us. I love the comments. Dr. Hayes, I already knew you were gonna blow up the comment section, so thank you, sir. And Dr. Malcolm is out there. Dr. Letitia Malcolm is out there, and I'm trying to see who else have I seen. But let me tell you something about what Dr. Rohn just said. When you are dealing with involuntary movement disorder or whatever disorder it is that you may be have to handle in your personal life, you should look for the teaching moments.
Yes.
Should look, and I know that's hard. That's very, very hard. It's hard to do when you're suffering from something. But let's look for the teaching moments. And that's why I do this broadcast, because the broadcast is to be a teaching moment. We're not to be afraid when we hear Parkinson's disease. We're not to be afraid when we get a certain diagnosis from the doctor. We're to look to understand what he or she is saying, and let's look to see how we can move beyond that, treat it, and let's move to healing. All right. That is the purpose for why this broadcast is here, to provide information and also to give the insight, because let me tell you, people are struggling in their minds when they hear about a leader, famous person, whoever it may be, athlete, stricken with such a movement disorder such as Parkinson's. Because here's the one of the myths, okay? And Dr. Graham, you could take this one. One of the myths is that people say that Parkinson's disease is fatal. Parkinson's disease is fatal, okay? Now, I want you to kind of take that. So what do I mean by that? Does that mean just because you have Parkinson's disease, that means that that's going to be the disease that's going to take your life? And I'll be honest with you, Dr. Brown, I've already heard that people say, oh my God, we got to start preparing now for the funeral for Bishop Blake. Dr. Graham addressed that, because y'all know I'm not scared to go there.
So I guess, let's go right there. As we said earlier, Parkinson's disease, we can't cure it, but we can delay it quite a bit, quite a long time. Depends on what papers you read. On average, before symptoms become debilitating, and depending on kind of what age and what the other underlying conditions are as well, 10 to 20 years is a range that you can see of people living still and thriving with the disease because of the treatments that we do have that delay progression. And as Dr. Rohn mentioned earlier, it's really key and important to do some of the even non-pharmacologic things, i.e. physical therapy, speech therapy, all of the therapies that he mentioned, occupational therapy as well, is if needed. All of those things can help. There is a very unique program here in Atlanta at an institution where they are doing Tango Dancing. And they've published on this, that if a person practices tango roughly 30 minutes, 2 to 3 days a week, they reduced Parkinson patients' falls and rigidity by tango dancing. And I'm sure the audience and maybe the doctors are like curious, well, why tango dancing? Well, what, as you guys know, tango dancing has these very like staccato type steps, right? So what that does is, for a person with Parkinson's, it builds kind of that motor innervation to the opposing muscles in either leg. And as a result, even with, so to speak, the decline associated with Parkinson's, having that increased muscle strength actually reduces the rigidity, i.e. then reducing falls, i.e. then reducing morbidity and mortality. And so if you think about it, hiring somebody to do tango 3 days a week with Parkinson's patients is much cheaper than a lot of the other interventions, right, that we're doing. And so what this group is doing out of Atlanta, there are actually some colleagues of mine who are doing this work. They're really trying to get this to be a nationwide tango intervention because their data is good. Any of you guys can Google it. Tango and Parkinson's out there in the literature everywhere. So I just bring that up as an example to say, back to Dr. Shepard's question, which is, this is not one of those, diagnoses that you get and immediately think about the end, right? It's not, especially if it's managed appropriately and intervened immediately, right? You don't have to think of it that way. And as you said, Dr. Shepard, I'm sure people in the grand old party feel like, oh my God, our leader has this, like you said, stricken with this disease. And I'm sure lots of thoughts of people who don't necessarily have the medical knowledge, of course, that we have, feel that way, but that's not necessarily true. As Dr. Rome mentioned, Michael J. Fox is like, what, year 28 or so? 20, I think he's like high 20, almost 30 years of having the diagnosis. Now, he's an exception. I'm not saying that that's definitely the norm, but I guess it's also an example of what could be possible, right? I'm not saying that's average, but what could be possible. So with that being said, I think people should not let the fear of the thought that it is fatal mean they don't do anything. Because I know that's what happens in our community. Sometimes people will get a diagnosis or they think they may have something and they've heard there's not much that can be done. It's like the thought of somebody not saying it, i.e. a doctor saying that to them, it makes them feel this false sense of safety. Well, I didn't hear it, even though I think I might have it. So therefore I don't deal with it. This is a disease where this is just not the right strategy to take. Well, actually, any of them, that's not the right. But since we're talking about Parkinson's tonight, I want to provide hope that if you got this diagnosis, it's not the end.
That's good. That's good. Bishop, did you want to say anything to that?
No. Well, he just said it all.
Okay, great. No, I mean that was awesome. Thank you for sharing that. Beverly Carter, you mentioned something, and thank you for saying that. The falls. Thank you. First of all, I lost my train of thought because you Beverly, you reminded me about falls, because people who have Parkinson's disease, they are prone to falling, and actually that's one of the major ways in which they die.
Yes,
because they'll break their hip or break a particular structure in their body, and that will lead to accelerated death. So that sort of wasn't the Parkinson's disease that killed him; it was the fall.
Yes.
And so, thank you for mentioning about this tango. Oh man, I love it. I can see some of these older ones out there taking some tango classes and things like that. Oh man, I would love to. I would love to see that.
If you want to see it, there's a YouTube video too. The research group has a YouTube video where they'll show you Parkinson's patients doing tango.
Wonderful. Thank you. Oh my Lord, we got somebody else from the Philippines who is watching. Maria is watching, and so thank you. I tell people we're international. We'll ask the doctors. I love it. And Audrey Moody, thank you, a consistent supporter. But yeah, I want to go back to what I was saying. Falls are definitely one of the things that we have to be careful of for those persons who have Parkinson's disease. I want to mention a couple of things, and then I'm going to talk a little bit about the mental challenges. And so let's look at this next one. It talks about some of the treatments, okay? Levodopa, if I'm saying that right, L-Dopa, okay? Tell us a little bit about that, because that's been out there. Can someone just tell me a little bit about that? Because when you go to Google it, that's going to come up as far as treatment. And so I know people are out there already Googling. So people need to know what they're talking about. So Dr. Brown, if you want to start, or Dr. Graham, whoever feels most comfortable with that.
Well, from what I've seen, Dr. Graham knows more I do. There are 4 drug classes. I know 3 of them: monoxide oxidase type 2, type B. That'd be like stuff like racilidine and sulfamide. Well, we don't use those too often. The dopaminergic agents of those are go-to: bromocriptine, praximexapol, carbidopa, levodopa. Anticholinergics are cholinergics are ones that we use as well. But the dopaminergic drugs are the ones we use the most. They actually just replete the dopamine stores that have been depleted to help people remain as functional as possible. Again, with the drug therapy, we're not reversing much. We're just maintaining function with what is left. Again, that's why we're trying to get involved as soon as possible. The thing about, and Dr. Graham, I'll let you take it from here. The thing about treating people with Parkinson's is there are some profound side effects with these medications. It's a caveat, okay? When you're treating Parkinsonism, you're trying to get rid of the bradykinesia and that type of thing, but you can actually induce psychosis with some of these drugs. Wow. And then, and I don't want to get too far ahead, but when we're treating the psychosis that develops sometimes, if you treat it with the wrong psychotic drug, it will induce Parkinson's symptoms. So you have to be careful to
That's
use
true.
a drug that's not going to aggravate the circumstance. Dr. Graham, what do you got to say?
Wow.
That's pretty good, Dr. Ron. That's pretty good. Yeah, I would just add to that, and a neurologist or whoever, likely a neurologist who'll be taking care of you, with the dopaminergic being kind of the first class of drugs that we like to go to. It's a fine dance. It's a fine balance. And as Dr. Ron said, once you find like that sweet spot of the dose that does not increase motor symptoms, it does not increase hallucinations and other things, and somnolence, you stay, and sleepiness, drowsiness, you stay at that dose.
Oh, yeah.
So if you take care of Parkinson's patients, and I know you do, Dr. Ron, in the hospital, I'm sure if you see repeat offenders, you typically see that same dose that they're on. Unless, someone feels like, okay, the symptoms are a little bit worse, let's go up just a little bit and see. But typically, kind of the rule of thumb is once you find that sweet spot that works and is not, worsening of symptoms, and the quality of life is decent, and also the motor symptoms are somewhat controlled, you kind of stay there. And what basically works for that particular patient. Because as you said, you can make it worse. Like, I have seen and I'm sure you guys have too, taken care of people who they're like, oh my God, the family will bring them in. I know when I was doing some hospital medicine, and they'll say, I don't know, like we went and we saw the neurologist last week and he only went up by like 0.12. And my dad is like, crazy, we can't deal with him. Like all this stuff is happening. So they bring him into the hospital. And all we do is reduce the dose back to the original dose, give it a few days. You've done this, right, Dr.
Right. Mm-hmm.
Wow.
Typically they're discharged in a few days and they're back to baseline.
Wow.
So what I would like to say to people who have this diagnosis, be vigilant to your healthcare provider as a patient to say, like, if they say, I want to increase it, like, hey, is that a good idea? Should we be worried about something? You want to say stuff like that because unfortunately the class and all the classes Dr. Ron mentioned of drugs, they all have their own unique set of side effects, right? And so the management of the disease is not an exact science. Like it really is to some extent, you try and see how people do, and then you pull back if it doesn't go so, well, until you kind of reach that spot. And so I guess you being aware of that as a potential patient who might have it, just so you know how to advocate appropriately for yourself, within, so to speak, our system and dealing with other physicians. It's just all I would add to kind of what he was saying in terms of treatment. But typically, I do want to speak positively about this. Once that sweet spot is found, people tend to do well. And you might see someone, and Dr. Ron, I'm sure you've seen this as well, possibly Dr. Shepard as well in training, where someone have been on like the same dose for 10 years. I have seen patients like that.
Wow.
And basically, if it's not broke, we don't fix it, right? And they're still functional majority of the day. And, all the quality of life indicators are still relatively high. That works. And you don't bother. So just so you guys are aware, that's kind of the mindset of the people who probably will be prescribing and treating you. That's how they're thinking about, how do I best approach you? Like, I want to control the motor symptoms, but I don't want to make things worse. So there's a very fine balance of that.
Right. So I just wanted to address Elaine Winfield. She mentioned that she had at least 3 concussions. Should she be concerned? I'll just say real briefly, Elaine, please make sure that you are connected to your physician, to your primary care doctor, so that you can be assessed, because we are probably not the best ones to answer that question. I will ask this question, though. Is there a connection between Parkinson's disease and concussions? Do we know if there's any link between the two?
It would just be the head trauma itself.
Yeah.
Dr. Graham pointed out that people
Okay.
fall and break hips, but
Mhm.
people also fall flat and make contact with the floor with their head, especially if they have one of the side effects called Shy-Drager syndrome, where they have this autonomic collapse where their blood pressure just drops while they're standing up and they get dizzy, they fall, pass out, and they're not even awake enough to break their fall with their hands, and they just literally make contact with the floor. That to me would be the greatest risk of a concussion, just because you weren't awake enough to break your fall. And that does happen a lot in the elderly, and not even people that don't have Parkinson's. The elderly people have all kinds of crazy ways that they fall. And so, Elaine, I would just add to Dr. Shepard, if you've had 3 concussions, you probably should be under the care of a neurologist.
Yeah.
And if you're not, I would ask my PCP, my primary care physician, to refer me to someone, especially having any kind of sequela, because with every, now I know this because my kids play football and I was the doc on the team. Okay. With every successive episode of concussion, you increase the likelihood of permanent brain damage exponentially.
Wow.
So if you had concussions and you keep falling, yeah, you need to get to somebody pretty quick.
Wow. Well, thank you. So informative. So, Elaine, we wish you well. Make sure you get connected to your primary care doctor. I want to deal with this because I am a psychiatrist, and I want to deal with the mental health aspect. And you alluded to this already with some of the dopaminergic drugs. I know we're using some big names out there, so I'm going to kind of break it down. So what happens if you were at the very beginning of the show, and thank you for those who are just joining in, and you all have maintained such a wonderful audience. I'm loving it. So what we talked about at the very beginning is that in the brain, there are some cells that die that contain dopamine. Dopamine was a neurotransmitter, all right? And so when they die, that's when we see Parkinson's disease. I'm just kind of keeping it very simple. Now, in my field, in mental health, when a person has psychosis, it's typically because they got too much dopamine. So I see the reverse. So a person who is suffering from schizophrenia, let's just say for instance, typically they have too much dopamine.
Wow.
And so we give the medications to reduce the amount of dopamine so that they can be able to function more appropriately within their thought patterns. All right. Hope you hear the connection. Because if you don't, I'm gonna even make it a little bit clearer for you. So when you lack the dopamine in the Parkinson's disease, then you give the dopamine because you want them to not have those involuntary movements and the bradykinesia and all the things that we've talked about. You're actually now adding on dopamine. And sometimes if you add too much dopamine, you're going to cross over to my field where you're going to have these hallucinations. You're going to have these various other things that people will make people think that you are not in your right mind. I don't use that word crazy, but not in your right mind. Schizophrenia, schizophrenic. And so that does happen. I want you all to speak to that. What I see is I see depression in Parkinson's disease.
Big time.
I see psychosis. I even see anxiety. Those 3. So yes, I can speak to it, but you all are experts. So and you're a guest on this show. So go ahead. From your vantage point.
Dr. Graham, why don't you go start?
Yeah, sure. So I guess, yes, anxiety, depression, big associated with Parkinson's. I would say in the nursing home, my work that I've done in the nursing home, I've seen this a lot with, especially getting closer to end-stage Parkinson's patients. There is this phenomena, and I'm going to mess it up because I'm trying to remember the exact name, but it's called like the old hag in the room. And basically it is a symptom or finding that you find all around the world in people with Parkinson's. And so in essence, what the person will describe is that there's like a woman in the corner of their room hovering over. And so medically people made up this, I guess, term to, so to speak, describe this common symptom or finding in patients who have Parkinson. And I think it's called like the old hag, I believe is what it's called.
Wow.
That is common in end-stage Parkinson's patient. And I've seen it a few times in the nursing home, like patients that were like 88 years old and had a diagnosis in their 60s. And now, they're approaching the end, and they will hallucinate and see You see that lady over in the corner? You see her? You see her? And they'll keep saying this like over and over and over.
Wow.
But the cool thing about it is, and Dr. Rohn alluded to this earlier, you actually do not give antipsychotics for this issue. It's weird. It's like it can either be you decrease if they're on a dopaminergic, like L-Dopa, you decrease it a little bit, and that sometimes gets better. Or depending on where you are in your dosing and where they are in the disease process, you may go up a little bit and it'll go away. But typically, if that L-Dopa level is about right, that particular, I guess we'll say pathognomonic, or in our world, kind of seminal finding in end-stage Parkinson's with hallucinations, this kind of old lady in their room, can be addressed by using basically the medicine to do either decreasing dose or increasing, but not giving antipsychotics, which, you would think maybe that would be the way to deal with it, but it's not. It actually makes it worse, as Dr. Rohn was saying earlier.
Yep.
And so that's the tricky part of psychosis associated with Parkinson's, is how you treat it is so different than typical, people who don't have Parkinson's, right? And they have psychosis. Like there's and Dr. Shepherd can speak to this better than I, but there's a very kind of set way you go about treating it. You can't do that with Parkinson's patients because the mechanism of those hallucinations are different. So therefore, that's why those typical antipsychotic drugs don't work, because the root, so to speak, of the problem is in a different part of the brain.
Gotcha. Oh, that's good.
I have a question.
Go ahead.
So, Dr. Graham, I was reading about dementia of Lewy bodies.
Yeah, that's
actually is associated with this with Parkinson's. They're not saying all Parkinsonism does this, but some of them have. And you and I know it's a postmortem diagnosis because you don't use the Lewy bodies as brain tissue. So they were saying that there are certain drugs that you have to use, the psychotic drugs, if you're going to treat a psychotic issue, and it's not the old heck thing, but if you're going to have to use these drugs, you can't use the typical ones.
Right.
Like olanzapine, quetiapine, those ones, because if you lose the Haldol and the old school stuff, you're going to induce more Parkinsonism. Can you speak to that a little bit? Your experience with quetiapine and olanzapine and treating these, since you're on the cutting edge there.
Yeah, so I have seen people unfortunately get worse because depending on who's taking care of them and their ability to stay up to date with what we should be doing in terms of the treatment. And as you guys know, it's such a variability in providers, especially, I would say, honestly, I've seen it the worst in the nursing home because, without being critical of others, but I think sometimes the level of people providing care, their expertise and comfort with the disease process is just not probably what it needs to be.
Yes, sir.
But they're still doing what they, so to speak, have to do. So I've gone in and covered a nursing home where there were Parkinson's patients who were on Seroquel nightly. And the nurses were saying, I don't know, ever since they put them on there, they're worse. And I'm like, yeah, they should be. And they're all like, what do you mean? They shouldn't be worse. And it's like, yeah, they're like, but they're psychotic. It's like, but yeah, that's not the right, drugs to use in this particular patient with their disease state. And so speaking to that, a little bit more, Dr. Rohn, I find that a lot of people don't know that. I'm an internist by training as well. And to be honest, I feel like my Parkinson's knowledge was basic until geriatric fellowship. Because as a part of my fellowship, I actually had to go to a Parkinson's clinic for a month and just see patients every day, which was great because I didn't realize as a geriatrician how much Parkinson's I was really going to see. And so they kind of gave me a crash course, I feel like, in how to manage and what to do and not to do. So when I did go out into practice, I kind of was ready for that. So when I saw these things that were being done, so to speak, inappropriately, I immediately knew what to do. Okay, we need to stop that. That's, you know what I mean? And this is what we need to do. And as you made that distinction, even between atypicals, antipsychotics, and that the knowledge of that, I think you'd be surprised how many people who are taking care of people with Parkinson's disease don't know that difference. And I do want to talk a little bit, if you don't mind, Dr. Shepherd, about Lewy body dementia. So without going into a whole dementia lesson, because I could go on about that forever, because that's what I do, but I'm not. Lewy body dementia, I think the most important thing for people to take away is this. It's typically the motor symptoms, so the rigidity, the bradykinesia, those types of things occur at least 1 year prior to any cognitive decline. So if you have a Parkinson's patient who's had all those symptoms for a year and then begin to have some cognitive issues, you can say fairly confidently, based on the guidelines, that, okay, this person likely has a Lewy body dementia. But if they, let's say the symptoms and the dementia start at the same time, likely not Lewy body. Maybe Parkinson's associated dementia, but not necessarily Lewy body. Like Lewy body has this very strict, defined, got to be 1 year of motor symptoms first, and then proceeding cognitive decline. So I'm actually taking care of a person right now who like literally meets that criteria exact. Started Parkinson treatment about a year ago, and now he came to me for follow-up recently, like a few weeks ago, saying, hey, I'm starting to have problems with like keeping up with stories, or if I'm reading something, I can't really focus as well, or if we're having conversations, I lose myself in the conversation. And that never happened to me before. What do you think that is? And so, of course, when I, read their chart and like, oh yeah, that's right, he was diagnosed with Parkinson a year ago. That's right, he's on treatment. Immediately makes me think that's likely the case. And so, without getting too much into the drug piece, because I don't want to go too far, that also provides a different treatment than Alzheimer's dementia, vascular dementia, frontotemporal dementia. Those treatment pathways are different. So it's important to be able to distinguish that just because you treat it not the same. I think that's all I'll say about that.
Yeah, no, this is good. This is good. We're going to start to bring this bring this discussion on in. This has been awesome. Dr. Rowan, what I hear for Dr. Graham, we're going to need to bring him in to have some larger discussions for our persons in leadership who are dealing with dementia, and help them to understand what dementia is, and help them understand that there's more than just Alzheimer's dementia.
Right.
I got Alzheimer's. Oh, actually, you might have something else. You may have vascular dementia, all those strokes you had because of your high blood pressure and everything else. Very well might be vascular, and it is treated differently. All right,
Yes.
and so we have to make sure that we're taking care of each other. Wow, this has been a awesome discussion. I'm looking at the comments. Thank you, Pastor Montez. Thank you, Pastor Edward Barnes is out there. And man, you all had Sheila Mason. Thank you. Yes, please go back and listen. And Julia Thusen is out there. Oh my Lord, she's even commenting. Thank you, Julia, from Kansas. Yes, Kansas. And so this has been excellent today. Somebody said, you're not going to have enough to talk about for a whole hour of Parkinson's disease. You were wrong. We've had more than an hour. It could go more, because I didn't even touch on the depression that is associated with Parkinson's disease. And so we will pick that back up. But I think this is a good stopping ground and stopping point, I should say. This has been awesome. Please let the people know where they can reach out to you. Dr. Roan, first, Dr. Graham next, and then I'll conclude. Dr. Roan, where can people contact you?
Oh, okay. You can contact me at RHONE Roan 213 at msn.com. I'll put it in the chat. Actually, Dr. Shepard put it in the chat because I can't see where to type.
Okay.
Roan 213. I can't type at msn.com. I'll be glad to field your comments and to provide any information and be helpful any way that I can.
Wonderful. Thank you. I really appreciate you, sir. All right, Dr. Graham.
Yes. So you can find me a few places. Instagram, I am doc Grant GRAHA all one word. You can find me there. I'm on Facebook just as myself, Antonio Graham. I also have a podcast called And the Question Is, and that has its own Instagram page, which is And the Question Is all together, one word. And you can find the podcast on anywhere you listen to podcasts, other multiple ways that you can reach me.
Absolutely. And I had the privilege to be on Dr. Graham's podcast. And I was listening to myself. I said, who is this talking? My Lord. They must have did some good editing or something. But it was a joy to be on his podcast. And I appreciate the camaraderie. This has been awesome. I'm telling you, I'm invigorated. I'm inspired. And so I hope that you all will go back and listen. Share this broadcast with someone else. Someone needs to hear this. I'm telling you, someone needs to get this information. You could not pay less than $100 an hour for the information that you just got here today. Some people will pay $1,000 an hour, depending on what Dr. Rohn charging. I don't know what he what he's charging. The pulmonology department.
Those critical care docs.
Right, yeah, I mean, you get an aspirin. Right. Anyway, we'll get off of him. But let me tell you, the information you got today is invaluable. My guests, please stay put. We're going to go ahead and sign off. Hope Health Systems, where I am the Chief Medical Director, sponsor of this wonderful broadcast, Ask the Doctors. If you're in need of mental health direct care, please let me know. HopeHealthSystems.com will do you some good. Reach out to us. Hope Health Systems, all one word, .com. See you later. I will have another inspiring, inspirational, and uplifting show for you in the near future. Take care and God bless.